All right. Hello, everyone. My name is Christophe Diaz, and I'm the Vice President of Scientific Affairs at Cure PSP. Welcome to our fourth Ask the Scientist webinar. Before we get started with introducing Dr. Höglinger, I'd like to share a few points with everyone. This webinar is intended to researchers and medical professionals. However, we welcome everyone and are thrilled that caregivers and patients are also joining these conversations. From a tech point of view, we're using a different platform this time. You're watching us via YouTube. Please type your question in the comment section of your YouTube window, and I will gather and address them and ask them to Dr. Höglinger after this presentation. Note that the question that will not be answered due to lack of time will be addressed and shared to registrants via a follow-up email. Today, our speaker is Dr. Günter Höglinger. Dr. Höglinger is a professor of neurology and translational neuroscience at Hanover Medical School and the German Center for Neurodegenerative Diseases, DZNE. Dr. Höglinger studied medicine and physics before earning his PhD in medicine in 2000. Since 2004, he has directed the experimental neurology research group at Philipps University, Marburg, Germany, where he became the vice director of the Department of Neurology. Since 2011, he has worked as a senior consultant at TUM in the Department of Neurology. He's also the chair of the Department of Translational Neurodegeneration at the German Center for Neurodegeneration Diseases. In 2019, he became the president of the German Parkinson Association. Dr. Höglinger conducts research in the field of neurodegenerative diseases with the goal of understanding the molecular mechanisms leading to the development and progression of neuronal dysfunction and death. He's also focusing on the development of diagnostic and therapeutic approaches for proteinopathies. His particular focus is the interface between preclinical and clinical research. In this presentation, Dr. Höglinger will discuss the value and purpose of the modified PSP-RS scale and the PSP-CDS scale in the context of available clinical tools, and we'll also discuss why we need these new scales. Dr. Höglinger, thank you for sharing your time and expertise with us today, and the floor is yours.
Yeah, thank you very much, Christophe, for your kind introduction, for the possibility to speak. Dear colleagues at the screens, thank you very much for your interest in the topic. I'm very pleased that I have the opportunity today to discuss with you the two new scales to monitor disease status and progression of patients living with PSP. We have just in international collaboration developed the modified PSP rating scale and the PSP clinical deficit scale. So the question is, why do we need these two new scales in presence of other scales that we have used in the past? Where is the advantages and where is the challenges that remain? So let me briefly introduce you in the field of PSP. I'm sure you're all very familiar with that. But it's just a couple of 50 years, actually, that we do know about the existence of the disease. Had been originally described by John Steele, Clifford Richardson, and Jerry Olszewski in a small series of cases observed in Toronto. And they observed clinically that these patients had a characteristic clinical phenotype which comprised eye movement problems, pseudobulbar palsy, dystonic rigidity of the neck and the trunk, and a small degree of dementia. Now, this clinical syndrome has paved its way into the literature under the name of Richardson syndrome and is currently considered to be the main clinical presentation of PSP. Meanwhile, we have learned that the disease is caused by aggregation of the protein tau, which is a microtubule-associated protein, and is in distinction to Alzheimer's disease, this is devoid of amyloid beta aggregates, and it does, in distinction from Alzheimer's disease, not only occur in neurons, but also is affecting astrocytes and oligodendrocytes. So what you see here in that slide is an immunostaining for phosphorylated 4-repeat tau, which is typically staining an astrocyte, and that's a particular pathological hallmark distinguishing PSP from other diseases. Now, when we looked in a series of 100 patients who came to autopsy and showed to have definite PSP proven by an autoptic report, and we looked into the early clinical spectrum of symptoms these patients were displaying, we recognized, in parallel with other researchers in the world, that Richardson syndrome is not the only clinical manifestation. In our specific case series, we observed that only 24% of the patients who came to autopsy actually had initially Richardson syndrome, and 75% of the patients had manifestations other than Richardson syndrome. So some of these patients had aborted Richardson syndrome, so that means isolated oculomotor dysfunction or isolated postural instability. But others actually initially looked pretty much like Parkinson's disease. Others, again, like frontotemporal dementia, and again, others like corticobasal syndrome. So that broadening of the clinical spectrum led us then to create an international consortium to revise the disease concept. We do now think that PSP is pretty much defined by autopsy, by the presence of 4 repeat tau in absence of other concomitant predominant proteinopathies in neurons, astrocyte, and oligodendrocyte. That is the definition of definite PSP. The clinical manifestation of this disease is most often Richardson syndrome, as we just got to know it. But there is also variant syndrome, such as PSP with predominant Parkinsonism, corticobasal syndromes, and others, which we would now label as variant PSP syndromes. And particularly, we also aimed to describe clinical syndromes describing the very early clinical situation, which is a pre-diagnostic manifestation of Richardson syndrome, and that was called suggestive of PSP. So this is the new concept. And in order to operationalize and to help clinicians to make the diagnosis of PSP during lifetime of the patients, where we reshaped the diagnostic criteria, we actually took the basis of the NINDS SPSP criteria, which had been developed in 1996. And we kept these pretty much as they were because they were characterized by great specificity. But in order to respect also the broadened clinical phenotype, we added additional clinical syndromes such as akinesia and cognitive dysfunction in order to capture also the patients who manifested who presented themselves with clinical phenotypes other than Richardson syndrome. Now, different combinations of these clinical features actually then allow us as clinicians to make the diagnosis, to predict the underlying tau pathology with different degrees of diagnostic certainties. And we label these diagnostic certainties as suggestive of PSP, possible PSP, and probable PSP. Definite PSP being, as I just said, the autopsy confirmed cases. Now, why is the measurement of clinical disease progression so important? This is because PSP is a progressive disease, as the name says, and as all neurodegenerative diseases, it's not a disease that comes and stays, it's a disease that progresses with time. When we looked into 200 autopsy-confirmed cases recently in an international collaboration led by Gabor Kovac, we observed that the PSP, pretty much like Alzheimer's disease and also Parkinson's disease, runs in and can be classified in pathologically defined stages. This is just a graphical representation. I don't go into details, but that shows you in a nutshell that PSP starts in particular areas of the brain and then with time evolves to affect also other regions of the brain. And that, of course, is concomitant with a broadening and a progression of the clinical symptomatology. So how does that look like from a patient's perspective? This is some core clinical features such as bradykinesia, slowing of repetitive movements, then eye movement problems, supranuclear palsy, postural instability and falls, cognitive dysfunction, dysphagia, and death ultimately. When we record the probability of these symptoms and signs to occur in patients over the years, 0 and 1 being the first year after symptom onset, we see that on average, these patients accumulate the probability to have this with a predictable manner. This hatched line is actually indicating the average of the probability to find these symptoms in individuals suffering from definite PSP over the years. Now, if we look at individual subtypes, such as PSP with Richardson syndrome, we see that the individual likeliness of getting these symptoms is pretty much divergent from the average of the majority of the group. So bradykinesia, supranuclear gaze pulse in patients with Richardson syndrome do occur at an earlier time point than the average group. If you look, for example, as patients with PSP and predominant Parkinsonism, we see that supranuclear gaze palsy and falls occur at a much later time point, and also death, for example, occurs at a dramatically later time point as opposed to Richardson syndrome. Now, if we look at the entire spectrum of the clinical phenotypes, we see that the clinical course can be very much divergent, just dependent on whether a patient with definite PSP starts his clinical career with Parkinsonism or with bradykinesia or with supranuclear gaze palsy. So that variability is, of course, in need to be described during the lifetime of the patients. Why do we need to catch that? First, the patients want to know where they are. They actually do need to know whether they are in mild, moderate, severe stages of the disease. They want to learn whether in the past 12 months, for example, their disease has progressed, how much it has progressed. So they have the right to know actually how severe their condition is and how steep the rate of progression is. We also need these measures of clinical disease progression for clinical research. This is a clinical trial, a disease-modifying intervention that we tested in patients with PSP, and to monitor whether the drug that we test, in that case it was tilavunemab, a tau-targeting antibody, whether that actually creates a difference in the rate of progression of patients treated as opposed to patients treated with placebo. We need to have reliable tools to monitor the disease progression over time. And in that case, we use the PSP rating scale to monitor disease progression over time. So it's also very much important for clinical research to have reliable clinical tools. So what kind of scales are actually available and are being used for PSP? Well, in the past, we have used generic rating scales. That means they are not specific to PSP, can also be used for other diseases than PSP. There is, for example, the MoCA scale, the Montreal Cognitive Assessment. That's more a screening tool rather than a progression tool to monitor the presence and progression of cognitive dysfunction. There is, for example, the geriatric depression scale that has been used in order to monitor the parts of depression of the patients. Then we have the clinical global impression scale. That's more a general impression of physicians to treat patients about their general health condition. And then we borrowed also some parts of some scales from the world of Parkinson's disease. These scales were mostly focused on the motor parts of PSP. So there is the UPDRS Part 3, which is a motor examination, originally developed for Parkinson's disease, but also being useful for PSP patients. Then there is an apathy scale, for example, originally developed for Parkinson's disease that has also been used in PSP patients. And the Schwab and England activities of daily living scale also pretty much useful for PSP. So that was the generic scales. And then we have rating scales at hand already right now that have been developed specifically for PSP. There is a PSP quality of life scale developed by Annette Schrag in London, which is very useful to monitor the quality of life of patients with PSP. There is a pretty new scale developed by Tony Lang and colleagues, the corticobasal ganglia functional scale, which, as the name says, is a patient-reported outcome and aims to monitor the functional independence of patients. There is a very slim PSP staging system developed by Larry Golby, which allows a pretty much course classification of the patients as to where they are in their disease course based on purely gait and postural stability as two independent features. And then there is the gold standard, the PSP rating scale. This is the standard scale that has been used mostly in the past clinical research of PSP. So what is the PSP rating scale? It's a scale that is a physician-rated measure developed by Larry Golby, originally published in 2007 in the Brain Journal. It comprises 28 items, and these items are grouped in 6 categories. These categories are daily activities, mentation, bulbar exam, oculomotor exam, limb motor exam, and then gait midline exam. To all of these 28 items, the physicians rate either 0 to 2 or 0 to 4 points, and that gives a total sum maximum score of 100 points, which is the worst condition ever imaginable. This scale is pretty much sensitive to monitor the progression over time, as you can see in that chart here. What is very particularly and uniquely appreciated at that scale is that it creates a very reliable progression within 1 year. So if you monitor patients at baseline and you look at them 12 months later, then there is a number of observational or interventional monocentric or multicentric trials that have pretty much observed the same degree of progression within 12 months. It's all about 11 to up to 13 points, but that's pretty close and very much comparable. So it's a very reliable tool to monitor progression. And therefore, it has been appreciated a lot in the past clinical trials, where it has been mostly used as primary endpoint, the 12-month progression in the PSP rating scale. What we usually do in science is if we run clinical trials, we do a power calculation that is, in a nutshell, the analysis based on natural history data to calculate how many patients per treatment arm we would actually need in order to visualize a true treatment effect in patients. In that case, based on the data we analyzed here in that study, we would need 50 patients per arm, so 50 per placebo group and 50 in the treatment group, in order to actually demonstrate that a drug that is really working does show a difference in that scale. And that's quite good as compared to the other scales that are around there. If we look at the individual subscores, the domains of the PSP rating scale, we see that the contribution of the individual subscores to measure the progression is quite variable. There is, for example, the gait score, which requires pretty few patients, and there is, for example, the mentation score, which would require many patients. So the individual sensitivity to measure disease progression of the individual sub-items is quite variable. That's already a point that might not be ideal in that scale. One very good additional aspect of that scale is that it also correlates with brain atrophy. We all believe that brain atrophy is actually the critical aspect why the brains of PSP patients do no longer function. If you lose neurons, then you have less brain capacity, and that should actually be a good biological surrogate parameter of neuronal demise in PSP. And the progression of brain atrophy correlates very well with the progression of the PSP scale, which suggests that the scale is also quite well linked to the underlying biology of PSP. That's a quite good argument also. And one additional good argument in favor of the PSP rating scale is actually that it seems to be able to measure not only sensitive, or that it does not only measure changes with time, but it seems to be also able to measure to measure changes induced by a therapeutic intervention. In this particular study, for example, we treated patients living with PSP with coenzyme Q10, that's the blue bar, or with placebo, and then we looked as opposed to the baseline characteristic, how the patients changed over time. And expectedly, the placebo patients worsened as measured with the PSP rating scale, and the patients treated with coenzyme Q10 improved on the scale. So that suggests that the scale is actually also able to capture changes induced by a treatment, and that's a good capacity actually of that scale. So with all these positive aspects being said, what are the limitations of the scale? There is a number of limitations that have been voiced, and I don't necessarily say that this is all my personal opinion. I just collected these limitations since these were put forward in the literature and in discussion with scientists. So one thing is that not all items of the PSP rating scale might be equally clinically meaningful. So there is these cognitive aspects, there is the motor aspects, there is the eye movement aspects, and it's true that not all of these aspects might actually confer a similar degree of handicap or limitation in the functional capacities or activities of daily living of these patients. So while it might be good to monitor all these aspects if you want to comprehensively describe the patient's status, not all of them might be equally clinically meaningful, and that's a limitation that has to be respected. Another limitation is that not all items actually contribute the same maximum scores. I told you already, some confer a maximum score of 2 points and others confer a maximum score of 4 points. So that means that individual problems that arise and are captured by the scale are not equally contributing equal amounts of points to the total score. And then some items might be somewhat overlapping. For example, there are 3 individual items that look into eye movements. There is upward, downward, left and right. And although that might be the same underlying neurological problems, it's captured by 3 individual items. So it might be somewhat overrepresented in contributing to the total score. And then there are individual items that might not all be sensitive to change over time to the same degree. So some might progress very rapidly, others not, and that might or might not be a good thing that can be discussed in details. So other items, again, might not be sensitive to change, and that means that they might not convey points to the total score. Also, the patients are still progressing in this particular aspect. So there are limitations that we addressed as scientists. And just to illustrate you, I give you here a couple of examples, like the first question, irritability can contribute maximum 2 scores, and dysarthria, for example, can contribute a maximum of 4 scores. And while it could be debated whether it's of relevance for the patient's quality of life and for their functionality, whether family interactions based on irritability are present or not, I think it's undoubted that inability to arise from a chair without assistance is definitely a severe milestone for a patient's life. So that's the limitations I wanted to put forward, and we tried to address these limitations in collaboration with Larry Golby and other researchers in order to provide a modified version of the PSP rating scale that might be of use for the community. So what we aimed to do is we aimed to retain the clinical meaningful items of the PSP rating scale. We aimed to eliminate those items that are actually insufficiently sensitive to change over time. We aimed to eliminate conceptually redundant items. That means, for example, if you have 3 items that look into the eye movements, we wanted to remain 1 for those only. And then finally and foremost, we aimed to calibrate these items against the semi-quantitative milestone severity grading. And that all with the aim to ascertain that the comparable numbers of modified PSP rating scores would actually always relate to a comparable functional impact for patients. Now, how did we approach that? How did we do that? So first, we did a survey amongst movement disorders specialists focused in PSP research from the European section of the International Movement Disorder Society. And we basically asked them for each individual item of the PSP rating scales, whether they thought that this item and every score in this item would actually constitute a clinically meaningful disease milestone with regards to the patient's quality of life, to the functionality in the activities of daily living, and with regard to mortality. And then they allocated scores to these individual items in the scale. So they attributed 0 if they did not think that this point would actually mean a relevant milestone. They attributed 1 if they thought this is a moderate milestone, and they attributed 2 if they thought this is a really severe milestone for the patients. So this is how we dealt then with each individual item. So you see, for example, here the gait item, which in the original version of the PSP rating scale has 0 to 4 points, 0 being normal, 4 being unable to walk. We asked the expert, and for each of these 5 items, 0 to 4, they allocated 0, 1, or 2 points, no milestone, moderate milestone, or severe milestone. And then we made the average of about 20 experts' opinion, and you see here the result of their opinion. That means 0, normal gait is, of course, no milestone. 1, that would be slightly wide-based or irregular gait, slightly pulsing on turns. That was also considered as being 0.26, so that's a very mild milestone. And then the item 2 must walk slowly or occasionally use walls or helpers to avoid falling. That was considered on average about 1. That is a moderate milestone. And the 2 last response categories must use assistance all or almost all times or unable to walk. Both of these were considered to be a severe milestone. So that was the raw data we obtained. And then we decided, okay, 0 and 1, response category 0 and 1, they contribute about no milestone, both jointly. And therefore we merged these response categories, and also 2, 3 and 4. They also were considered both as severe milestones. So we also merged these. That means if a physician in a given patient would report in the original version 0 or 1, we would in the revised version actually then label that as a 0. If a physician would report in the original version a 3 or a 4, we would merge these and report a 2 in the modified version. And by that, we had a linear stratification of the response categories to the milestone severity grading that was reported by the experts. That was the first step that we did. The second step we did was power calculation. So for each individual of these items, we did power calculation based on data we obtained from prior clinical trials. And we looked at their sensitivity to change. We implemented sensitivity thresholds and eliminated those that would actually not confer sensitivity to change over 12 months. So that was the approach. And by that, we went through item per item, and we calculated, reshaped the scale in a way that always the response categories were 1, 2, and 3. And the severity grading as provided by the physicians was always also 0, 1, and 2. So that was a recalibration against the milestone severity grading. When we then compared the modified scale with the original scale, we saw that both total scores, PSP rating scale here, and modified PSP rating scale in the same patients were actually very well correlated. So that means the same information is contained in the modified version as opposed to the original version when we look cross-sectionally, but also if we look longitudinally, so the change within 12 months, either reported is with the original scale or with the modified scale, then this is also linearly correlated. In both regards, we tend to conclude that the modified version does not lose relevant information as opposed to the original scale. Now, the important question with regards to trial design issues is, can we also use the modified scale in order to plan clinical trials? For that purpose, we did a power calculation for a study that was treating patients for 1 year, 52 weeks. And when we did the power calculation based on the data we had at hand here for this study with the original scale, we would have required, in order to detect a 50% change by the treatment, nearly 40 patients in order to visualize that. With the revised version, we would have required about the same numbers of patients. That means that the revised version, the modified version, has about the same sensitivity to change as opposed to the old version. Now, when we try to consider a shorter trial, not 52 weeks as done here, but 26 weeks, half a year, we would of course require higher numbers of patients per arm in order to visualize the differences between the treatment and the placebo arms. But again, here, the PSP or rating scale original version and the modified PSP rating scale would require about the same numbers of patients in order to get that shown. So this was then the next step. The next step was to ask patients how they felt about the clinical meaningfulness that was contained in the individual items. One of the limitations of our work was that we based our judgment on experts rather than on patients. That was clear to us from the beginning. We purposefully took that approach for a number of reasons. But we wanted to make sure in the end still how patients felt about the product that we generated. So for each of the individual items that we have used for the modified patient PSP rating scale, We compared the rating about the milestone severity grades that patients reported to the milestone severity grading that had been reported by the experts. And you can see here that this is quite nicely aligned. So the more severe patients considered a particular feature, the more severe it was rated by the experts. And I think the correlation is quite well. So the coherence between the patients and the experts' opinion on the items selected for the modified PSP rating scale is quite sufficient, I think, in our understanding. Now, what we did was we wanted to create as our main objective a condensed version of the PSP rating scale. We wanted to incorporate mainly the functionally relevant features. And by that, we did, in a systematic stepwise approach, reduce the number of items in the PSP rating scale from 28 in the original version to 14 in the modified version. We think that the modified version also is capable to measure functionally relevant disease progression in PSP, and that it really captures disease milestones in PSP. I think the data show that they are sensitive to change, but that needs to be, of course, confirmed in an independent patient sample. And the patient survey we did suggests that there is a quite good consistency of the patient's perspective on the items as opposed to the expert's rating. So that modified scale might serve as a scale for clinical routine to monitor the disease status and progression in patients, but I think it might also be quite helpful in clinical trials. So the next scale we aimed for is the PSP clinical deficit scale. So why did we develop that? The PSP rating scale originally had been developed for patients with Richardson syndrome and focuses quite a lot on the features like postural instability, locomotion, and eye movements. Now, the patients with PSP suffer from a broader spectrum than Richardson syndrome. That was a limitation we thought might be worthwhile to be also reflected by developing a scale that would be useful for the broader spectrum of PSP phenotypes. We aimed to go for a physician-reported scale for a number of reasons. I think we can discuss that also later on in the discussion, but we took purposefully the decision to develop a physician-reported scale. So how did we start here? First, we went to analyze the literature, and the question we asked for the published literature was which signs, symptoms, and syndromes are usually present in patients with neuropathologically defined PSP. And we particularly focused on items that we considered to be of relevance for activities of daily living in the patients. What we identified was more than 100 studies. We looked at them in detail, and we found 7 domains that were foremost present. That was akinesia, bradyphrenia, communication, dysphagia, eye movements, finger dexterity, gait, and balance. And in these domains, we then tried to develop 4 response categories, 0 being no deficit present, 1 indicating mild deficits that would be present but would not affect the activities of daily living, 2 being moderate deficits that would necessitate occasional or partial external support to maintain activities of daily living, so a small impairment of ADLs that would be compensated by external help, and 3 being a severe deficit that would incapacitate activities of daily living and require continuous external support. So this was then the scale as we conceptualized that. We discussed that up and down and back and forth with experts in the field and came up with this scale. So you see here the functional domains, and you see then the severity scales, the severity scores. Each of these individual response categories is well defined, and you can then actually add for each of the functional domains a value of 0 to 3, and you add that up to a sum score, which then would be the total rating scale. So we developed a user instruction that we also took a lot of time in order to explain what this is intended to. We wanted to develop a scale for research and clinical practice with these 7 functional domains relevant to all clinical phenotypes with the rating scores from 0 to 3, as I just outlined. and that was intended to develop a scale with larger numbers indicating larger impact on the patient's activities of daily living. The sum score then provides a value of 0 to 21, 0 meaning no deficit in no domain, and 21 severe deficits in all the domains. So then we did a semi-structured interview with patients and a caregiver, and we provided a framework how to do that structured interview with the patient and a short structured clinical examination that was used in order to collect the data to be reported in the scale. So that is an example of how that user instruction goes into details for each of the individual items. We tell you how to examine the patient, how to ask the patient about the presence and absence of these symptoms. And then we explain particularly also for each individual response category how we define how the features are defined in detail. Now, the data in order to validate this new scale have been generated in 2 German networks. The first is the Describe PSP network, which is run by the German Center for Neurodegenerative Diseases. And the second independent parallel network is run by the German Parkinson's Foundation, which is called the Pro-PSP study. So the samples we collected was in Describe 88 PSP patients, 55 of these with Richardson syndrome and 33 with variants. In the Pro-PSP study, we collected data from 76 patients, 52 of them being Richardson and 24 being variants. The first was used as exploratory study cohort, and the second was used as confirmatory cohort. So what we found was that the PSP rating scale, the gold standard scale for PSP, and the scores obtained with that scale correlate well with the scores obtained with the PSP functional disability scale, clinical deficit scales, which is good. So the scales provide a very similar information. The higher the number on the PSP rating scale, the lower the score of the Schwab and England activity of daily living scale, which means that the scale is obviously also capable to monitor activities of daily living of these patients. This is another way of presenting the data. We have grouped the patient's response categories in the PSP clinical deficit scale here in tertiles, so 0 to 7, 8 to 14, and 15 to 21 on the scale. And if we group patients according to other measures of functional impairment, such as the MoCA, falls, frequency of falls, dysphagia, being present or not present, walking aid, then you see that with increasing tertiles on the scale, you see also an increasing impairment of the patients in these functional external measures that monitor the inability of the patients to participate in the daily living. So that is also good news. Then what we also did was inter-rater reliability testing. That means that different physicians looked at the same patient, and we had a very good inter-rater reliability. We looked at test-retest stability. That means that one physician looks at the same patient one day and a couple of days later, and again, the repeated scoring yielded quite reliable test-retest stability. Then again, we looked at the sensitivity to change within 12 months, and here the PSP clinical deficit scale required somewhat more patients as opposed to the PSP rating scale in order to visualize a true difference. So the sensitivity to change is a bit lower, but I think it's still, in comparison to other scales that we have at TENS, quite acceptable. So what we have generated here is a scale that aims to be useful for research and clinical setting. It's a very slim and easy to memorize scale. That means it's done in a couple of minutes. If you know the scale, if you know the patients, you know what you look for. This is really very helpful, particularly in clinical routine settings, to be accomplished in a couple of minutes. In our understanding, it's useful for all clinical phenotypes, not only Richardson syndromes. It focuses on a broader spectrum of disease-relevant clinical deficits. It has very clearly distinct response categories, so I think you do not really need to think a lot whether the patient requires a 0 or a 1 or a 1 or a 2. I think it's quite distinct, and the way of answering is easy to do. It's time effective. It consumes a couple of minutes. There is no need for extensive training. It's easy to memorize, and it shows a fairly good sensitivity to change. So in my understanding, in our understanding, I think particularly for busy clinical routine settings, this might be a quite helpful tool to know and to memorize where the patient is. If you see the patient again in a year, you know what happened and what changed. So modified PSP rating scale and PSP clinical deficit scales, 2 new tools to track progression for PSP, both with regard to Richardson syndrome, but also with the variant PSP syndromes, need to be validated, of course, with independent cohorts by independent researchers. Especially in the early clinical course, we do not have a lot of data in the patient suggestive of PSP, which is also a task that we have to accomplish. And I hope that we have provided useful tools that might be of help for research and clinical research. With that, I like to thank you for your attention. I like to thank all these gorgeous people that I have the pleasure to work with. On top, you see the International Movement Disorders PSP Study Group. Then in the middle row, you see the members of the German Parkinson's Society Study Group. And below, you see the members of my team at Hannover Medical School. So thank you very much for your attention.
Thank you, Günter. So I've had some people submitted some question by email. A reminder that if you have questions regarding Dr. Höglinger talk, submit them in the comment section here. So there's I'll start with some of the questions I've had by email. You mentioned when you don't talk about the Richardson syndrome PSP, but the broader spectrum PSP, and you mentioned that there are many different phenotypes. Can you comment on the heterogeneity of these phenotypes over time for a given group of patients? Do you see a commonality how one phenotype succeeds to another, or do you see a lot of heterogeneity in some of the phenotype succession in disease progression?
Well, that's a very important question that we are all as a global community currently addressing. I mean, if you look at from a distance and look at the typical average patient with PSP Richardson syndrome, we know very well from the past 20 years of history of literature how these patients progress. We know quite a bit now about PSP with Parkinsonism. We know this is a quite benign course with a life expectancy that is much longer than that, probably double the life expectancy on average. But especially for the rarer phenotypes that had not yet been described so well in the literature, such as PSP with frontal dementia, we have very little information. And that again, I think is quite superficial knowledge, because we did not have the operationalized criteria in the past in order to collect these patients in a standardized manner. Now, with the Movement Disorder Society diagnostics criteria, I think we have the conceptual framework in order to do the longitudinal observational studies in order to generate that data. And I think there is even more heterogeneity within these groups. If we look at individual patients, it's probably genetics, like the LARC2 paper that had just been published by Hugh Morris and colleagues. I think there is individual variability that can be determined by fluid biomarkers such as NFL. Adam Boxer has just presented a couple of good data on that. So I think it's an important task to monitor disease progression, and even more so to predict disease progression. And for that particular task, it's important to have the tools at hand in order to quantify the status and progression.
Thank you. Another question regarding the PSP-CDS. As you mentioned, this one is developed primarily for a physician and neurologist. And one of the big challenges in PSP is to increase early identification of patients. And can you discuss whether some items of the scale that you develop could be utilized for the medical practitioner that are, at the beginning of the patient journey, so like an urgentist or neuro-ophthalmologist? And I know this might be a challenge, but is that something that you're thinking about in the development of the PSP-CDS?
Yeah, we had that in our mind, of course. It was not the primary purpose, but I think the need for screening tools in settings other than neurologists' specialized practice is obvious. So I'm not sure it's a good idea actually to look at that scale, whether that serves for this purpose. We were thinking about similar questionnaires that might actually serve that purpose, but I think it's a good idea to look whether this scale is actually already doing a good job in that. We also thought about putting such questionnaires online for patients seeking help in the internet, for example, having unexplained clinical features, no physician at hand who would be able to interpret that. Not sure whether this scale is actually fit for that purpose, but it's definitely a area of research that requires more attention. I think we would be more than happy to collaborate with Cure PSP and other patient organizations in order to facilitate the early recognition.
Yeah, that's great. A general and perhaps tough question here on the chat from Bruce Morimoto. Excellent talk, Günter. What has been the reception of your new scales from regulatory authorities?
Not sure whether I'm authorized to talk about that. It has been submitted, but I think I am not authorized to talk about that. But it's incorporated. The modified PSP rating scale has just been published, so this has not yet been submitted. The CDS has been submitted and is being incorporated. Whether or not this is the end of the development of new scales for PSP, I think is difficult to say at this moment in time. We are certainly asked to focus very much the patient's perspective, and we are certainly very much asked to focus on functionality of patients. Whether or not this scale will be fit for that purpose will have to be demonstrated in the future. And of course, we are open for more work in that field. I think it's difficult to answer at this moment in time whether this is already the end of the history.
Sure, and I guess a more general point of view is, maybe you could discuss what could be the next steps in connecting, the clinical research to eventually developing a tool that has utility for actual deployment in a clinical trial, right? So in your mind, what are the next steps that needs to happen
So obviously, the regulatory authorities ask us to watch out for the functionality of the patients and the well-being of the patients. So whether patients have rapid speed with their finger tapping is no relevant at all. Whether patients can actually brush their teeth and so on and rest themselves, this is of course very meaningful. In PSP, in my understanding, we have a particularly challenging situation because patients, as you know, sometimes have a striking ignorance with regard to the present clinical deficits. So that is sometimes also reported in the literature as diagnostic features, like the rocket sign, when people with PSP are shooting out of the chair to stand up and then fall back, driven by their postural instability. Just a second later, they again jump up and fall back because they ignore or they don't recognize the existence of these problems. The same is true for swallowing, for example. There might be severe dysphagia. Still, patients are overstuffing their mouth in order to do some kind of binge eating. This is I'm trying to be very respectful with regard to these problems, but I think that this decreased sensitivity to the presence of obviously present deficits in patients needs to be respected if we consider patient-reported outcomes in that particular population. And therefore, yes, I fully agree with the regulatory authorities and their request to consider and to have the primary objective to monitor what is of relevant for the patient. Whether the simple solution is to ask the patients, I'm not sure about that. And therefore, a lot of room for more research in that regard.
Yeah, there's a lot of room for discussion there. And a little bit related, when you talk about defining clinical meaningfulness, Maybe a few points on what is the specific challenge for PSP to define this clinical meaningfulness measure. Like, is it like, when you think of the protocols and the approaches to define those concepts, what are the specific challenge for PSP patients that are now addressed, but that are challenging the community?
Yeah, so I think I also, again, to that question, I do not have terminal answers, because the more I dive into that area, the more I see it's really a philosophical question that we address, and there is no gold standard answer to the question of what is clinical meaningful. I think there is a lot of intercultural difference in the interpretation of this question that might relate to the priorities that patients have in their life. For some people, it might be utmost important actually to drive their car. For others, it might be more important to communicate with their families. So I think I don't have a definite answer, and I think we need clear guidance from the patients, and we have to address that probably in different cultural context situations to see what is uniformly of relevance for their functionality. And function is not just functioning as a professional worker. Function is social functionings. Function is social interaction. Function is foremost well-being of the patients. And therefore, I think this is really also a challenge that is not solved. And therefore, also the regulatory authorities do not provide us a clear goal. They just say, go into that direction and ask the question to patients, what is really relevant for their well-being and for their function.
Thank you for that. There's a question from a patient that also relates to the challenges in defining some of those measures. The question is, does my PSP starts with the date of my diagnosis or the date of my first symptom? And the reason I'm bringing this question to the conversation is because that's the big challenge in trying to diagnose patients as soon as possible. But maybe if you could address that for this patient and for the audience there.
Yeah, well, PSP, as well as much as most of the neurodegenerative diseases, probably starts somewhere long before you recognize your first symptoms. I have shown you these schematic brain drawings from the pathological spread of problems in the brain, that is tau aggregation. And long before the first symptoms arise, probably the first tau tangles appear to exist in the brain and then to spread throughout different areas. Now, when the first symptoms arise, this is the moment when the degeneration of neurons reaches areas in the brain that are clinically relevant, and not all areas in the brain are actually clinically visible, but some are. So the midbrain in particular for PSP patients is pretty much important because it's related to eye movements and it's related to the slowness of movements. And then as the degeneration goes on, the symptoms spread to incorporate also other cognitive and motor and locomotor aspects, emotional aspects also in PSP. So this is the starting point of the disease. Probably nobody will be precisely able to determine when and where the disease starts. But the time of symptom onset is also quite difficult to identify, because it's usually not, as in a stroke, for example, the vessel occludes and then you have your symptoms a minute later. In PSP, it's a steady accumulation of tau. It's a steady degeneration of neurons, and the symptoms also do not start suddenly, but they just start very, very, very slowly. So it's not a given moment in time, it's more a process. And then from the first symptoms coming to the attention of the patient, it takes a while until you go to seek a doctor and until the first doctor actually is able to monitor the presence of the disease and to spot that this disease is indeed PSP. So onset of the disease, onset of symptoms, and the diagnosis. That's the three distinct points in the patient's career.
Thank you, Günter. So before we close, I wanted to maybe give you a bit of a chance to tell us about some of the ongoing work you're having in your lab at this point that is relevant to PSP science and PSP community. To spend a couple of minutes on that. What's keeping you up at night and your team there in your lab?
Well, we are translational neurologists, so that means we try to focus on the disease with the full spectrum ranging from molecular work to clinical work. What we do is we start with patients. We develop these clinical tools that we have just talked about today. We are doing a lot of imaging, MRI, to allow the diagnosis, but also to track the disease progression. We have invested a lot of time now in tau PET also as a tool to monitor the progression, the presence and the progression of tau in the brain. I mean, this would be, if it works in the end, an objective biomarker to enable us to make an objective diagnosis of PSP, hopefully in the very early clinical stages. Then we have prospective cohorts ongoing. I talked about that, where we are collecting biospecimen in order to develop new biomarkers, protein biomarkers, mRNA biomarkers. We do get genetic work, and foremost and most important in my understanding, we're also trying to feedback again the information gained in our experimental work into clinical trials. So we have a couple of therapeutic clinical trials ongoing where we test new antibodies, antisense oligonucleotides, for example, whether or not that serves for decreasing the progression rate of PSP.
Thank you. So there's no other questions, so we'll close the talk. So thank you so much for your presentation and for answering all the question here. So I also want to thank you, Jacqueline Zandrian, that is backstage, making sure that everything works well and has been putting this webinar together. Feel free to reach out with any additional question, and you could sign up to our newsletter at www.psp.org to learn more of our ongoing webinar and ongoing research and activities. So goodbye, everyone. Thank you again, Dr. Höglinger. Have a great rest of the week and weekend, everyone. Thank you.
Thank you very much. Bye-bye.
Bye-bye.